So, hello, Sarah.
Hello,
Welcome.
Emma.
Welcome to this World Menopause Month talk. We are here today. We're going to talk all about World Menopause Month, cardiovascular disease, menopause, everything. But I'm going to introduce you to everybody listening or watching. And I think that's really important where everyone actually really understands. I know you as a colleague and a friend. We work together in a menopause clinic for quite a number of years. And we both share this enormous passion for women's health, menopause, perimenopause, just all of that, the health around that, and lifestyle health and everything connected with that. But you're a GP, a fully
I
qualified
am.
GP in the UK, and you developed this real passion for menopause. And in fact, so much so you were invited to join this menopause clinic, which is where I met you. And you just have developed this immense knowledge and skill level of all the factors that go into a woman's health during that time and beyond, of course. And I think your knowledge is immense, and your thirst for understanding all the various facets of this stage in a woman's life is phenomenal. So it's fantastic. So thank you so much for joining me.
Oh,
And
it's a pleasure. You are.
especially, yeah, exactly. Especially because your newly open clinic, Health in Menopause, is very exciting for you. Sorry.
Yeah, yeah. I think yeah, I mean, when you're a GP for so long, you obviously see all sorts of things and you learn how to manage all sorts of things, but unfortunately you're very stretched in terms of resource and time. And so traditional medicine, I suppose, has become a lot about drugs and operations, but we've forgotten the basics in mainstream medicine, I would say. And so one of the joys of actually leaving the NHS, although it was a very difficult and sad thing to do in many ways, has been able to connect with people like you and many other amazing practitioners, and actually being able to go right back to basics about what it actually is to be a doctor or a healthcare professional, and actually look after somebody holistically, and actually say, yes, okay, I can prescribe you drugs and medication. Yes, I have those qualifications, but actually, do I need to? And shall we look at everything else? So, how are you eating, and are you exercising, and what's your sleep like, and do you have good social connections with others, and looking at everything that makes us a well or not well person. So I also have a lot to thank you for, because it's, to actually spend quality time with someone that's equally passionate about how healing food can be has really helped me. So it's nice that we can have this sort of symbiotic relationship, that we learn and feed from each other, don't we, in terms of our knowledge and experience with women.
Yes, very, very much so. And we actually work quite closely together on our original discoveries around histamine intolerance and how that impacts a person in perimenopause and menopause as well.
Yeah.
And it was a real steep learning curve for me, and I think initially it was for you.
Absolutely, yes. And we
Yeah.
still don't know enough, but that's,
Yeah. Yeah.
we're learning that in a lot of medicine, especially anything medicine to do with women, that we usually don't have as much information as we would like, because it's never been studied enough before. But we're making progress, so we're learning more and more as we go along.
Yes, yes, so much so.
Mm.
So thank you for that, Sarah. I wanted to just set the scene, if we can, and just help the people watching and listening to have an understanding of what perimenopause and menopause is, and for that matter, postmenopause, and just an understanding of what might typically be going on and what it means, those
Yeah.
stages or those
Yeah,
phases.
absolutely. So I think when we start our periods as women in our teens, usually, we then get into usually a monthly cycle where our hormones are fluctuating, and those hormones are estrogen and progesterone, because they come from the ovaries. So usually during our 20s, 30s, that's usually, not for everybody, but it's usually a fairly straightforward cycle that we have. But then for most of us in our 40s, that slightly starts to change, because our ovaries are starting to tire a bit, and they're struggling to do their job as easily as they did. So our hormone levels start to fluctuate. So we go into this stage called the perimenopause, where we're still having a monthly bleed, usually, although those bleeds may have changed. But because our hormones are fluctuating, we may start to notice symptoms. The difficulty is, though, that because most of us aren't aware that that's going to happen to us, we often don't join the dots and realize that those symptoms actually relate to our hormones and not to other things. So characteristically in the perimenopause, which for the average woman is usually going to be in her 40s, we'll often start to experience things like anxiety, poor sleep, maybe slight changes in things like our joints or our hair or our skin, or even symptoms that affect the genitourinary area, like maybe vaginal dryness or discomfort in the vagina, or urinary issues, having to go more, or with more urgency, or getting cystitis or urine infections, for example. So often there may be many trips made to a GP with all these different sort of symptoms, where often people aren't joining the dots and realizing what that all means. But because periods are ongoing, it's often not thought. Hormones isn't often the first thing on people's minds. The menopause technically is your last menstrual period, but we don't know it's our last menstrual period until we've gone another whole year after that date and there's been no more periods. So menopause technically is just one day in your life. And for a natural menopause, so when the ovaries have just naturally declined and then stopped, the average age for that is about 51. And that's why that build up, that perimenopause, which is almost like the crescendo to the final swan song of your ovaries, is usually in your 40s. And then once you've reached the menopause, forever after then, you are postmenopausal. So you are never going to get your ovarian hormones back again unless you choose to take them back as a medication. So I think traditionally people have thought, oh, menopause, that's just, I don't need to worry about that at the moment because that's probably about my early 50s and it's just a couple of years and then that's done. And people compartmentalize it and don't maybe give it the due attention and forethought and sort of planning that actually would be best dealt with. So and what's important is that menopause has many symptoms attached to it, even more than I've said. There can be other things, so the hot sweats and flushes that are most commonly thought of, things like migraine, low libido, very low energy, and then a lot of mental health issues, low mood, anxiety problems, for example. So all of those symptoms can be very problematic. Not always. Some people actually do fairly well, but some people really, really struggle. So managing those symptoms with a mixture of lifestyle things and considering medications such as hormone replacement therapy are really important. But the other really important thing that we need to think about with relation to menopause is the future implications that losing our hormones have on our overall health. So, you know, our brains and our heart and our blood vessels and our bones actually are all very dependent on the hormones that are made from our ovaries. So we need to factor all of that in, which is why we love World Menopause Day, because we often get to celebrate those specific areas of menopause that not everybody knows about.
That's right, because I think when someone's certainly in perimenopause and beginning to get those symptoms, and you're right, if they're not aware of what perimenopause is, they think, what is going on with me? And it's kind of really can be a crazy time or a very stressful time. And then they go into menopause and their focus is still very much on that sort of new menopause thought process and still the hot flushes potentially and all those other symptoms you talked about that are going on immediately at that time. But that future health, their thoughts are not on, oh, what about my cardiovascular disease risk now that I'm in menopause and things like that, because estrogen and progesterone is so protective, or estrogen especially, or you can correct me on that. And so this year, the World International Menopause Society would like us, for World Menopause Month and World Menopause Day, would like us to focus on cardiovascular health. And I think fantastic, because actually it pulls in the treatment for that. When I say treatment, the lifestyle and perhaps drug treatment for that, or hormonal treatment, in fact helps everything else as well. So when we focus on cardiovascular disease, in fact, it helps so many other symptoms that are going on. But
yes, exactly. And I think so few people have that understanding, and it's nobody's fault. It's because it's never really been a priority in healthcare settings, is that actually our menopause has a huge impact on all of our other health systems. And it's so closely tied up that to not address it would be foolish, in the same way as if you had someone who was diabetic and you didn't manage their diabetes, so many other bad health outcomes would come to them as a result of that. And we need to actually proactively manage the menopause, not wait and see what happens, because that's not a very sensible way of doing it. And I just also wanted to say, I kind of talked there about natural menopause. Actually, there are also a fair proportion of women who come to menopause in other ways. So they may have their ovaries removed, for example, or they may have treatment for other conditions, say cancer, where they have some maybe chemotherapy or radiotherapy, and that actually damages their ovaries. So it's although natural menopause is still the most commonest way of reaching it, it can also be caused by medical treatments, or menopause can actually happen much earlier than the average, and sometimes in very young women. So we need to apply the messages to everybody, and not just stay in this box where we're just talking to women in their 50s, because actually that would miss so many important opportunities for empowering women with knowledge.
yes, absolutely right. Exactly. That's right. So really, we're not talking about an age group here. We're talking about the health for us through our lifespan, or our adult lifespan. Absolutely. Yes, very so.
Yes. And you might have heard me say before, but I always think it's a useful analogy, that I always think of menopause as a bit like half time in a football match or a netball match or whatever sport you like, in that, you've usually given a lot in the first half, and that for many of us might be how well we've already lived our life, and whether we've eaten well, and whether we've exercised, and whether we've already looked after ourselves. But actually we now need to actually take 5 while we have half time, and work out how are we going to make the second half either just as good or potentially even better, and try and avoid the obvious pitfalls that come when you're in the second half of anything, when you are getting a bit tired and you've maybe lost some players. In other words, you might have lost your ovarian hormones, but what could you do as substitutes? And it's about, in Victorian times, the menopause was very much towards the very end of a female's life, because she'd done her job of reproducing, which is what evolution kind of intended us to do. And then our job was kind of done. So the fact that menopause happened wasn't as important way back then, because we weren't going to live that much longer on average after the menopause. And certainly in Victorian times, women didn't tend to have younger children at an older age. Their parents would unlikely have been around at this age, because their parents would have usually already passed on. And so we now live in this very different world, where menopause often comes near the kind of halfway stage of our life. And yet we don't want to. I would like to live a long life, but I would like that long life to also be a very quality life. I don't want to be old and frail. I would like to be old and well. And so thinking about menopause way back in our 40s is actually a really good way of trying to get that situation as good as it can be.
Absolutely, absolutely. Complete longevity thoughts as well, most definitely. I was actually looking up some research just before we had this conversation. And in fact, cardiovascular disease is the leading cause of death in women post-menopause. So I thought, wow, okay, it outstrips men. We women outstrip men once we get into menopause. And so no wonder the International Menopause Society wants to highlight it this year.
Yeah. It's absolutely huge. Yes. So across the world, 1 in 3 women die of cardiovascular disease. I mean, dementia is also high up there. So, you know, the biggest threats by a long shot for women in the UK, but also westernized countries is dementia and cardiovascular disease. And actually they overlap in many ways in that most dementia relates to poor health of your blood vessels. And so really you can sort of lump them together. It's just that we have a lot of confusion, I think, because when we're before our menopause and we have all this estrogen, women are very protected by estrogen. It keeps our blood pressure good, it keeps our sugar levels good, it keeps our cholesterol levels good, and it keeps the flexibility of our blood vessels very good as well. So we're really protected. So it'd be really unusual to hear of a woman having angina or a heart attack, for example, before her menopause. It's not impossible, but it's very unusual. Whereas men, they don't have all this estrogen, so that actually they don't have the level of protection we have. So you will sometimes hear that men in their 40s or 50s do have angina and heart attacks. And so we have this advantage, but we then lose that advantage at the menopause. And then what happens is over about the next 10 years after our menopause, we kind of catch up. And then what happens, which is really sad, is that during our 60s and then into our 70s, women actually overtake men then. And that's for a lot of reasons, but it's predominantly because medicine in the westernized world has already always been based on the masculine body. All the diagnoses, tests, they're all based on an average man. And women haven't been involved in trials of anything until the 1990s. So actually the tests and the treatments and the understanding is nowhere near as good for females. So the sad thing is that although in our younger years we have far less heart attacks, in our older years we have far more, and at any age a woman is more likely to die of a heart attack than a man. And so it's really important that we tackle this. I think younger generations think of heart attacks as things which happen to old people. You know, they might have a grandparent who's had a heart attack in their 70s, and it feels so remote that a lot of people, I think, don't take proactive measures to try and prevent that. But actually in a similar way to dementia, the changes that are going to result in that illness down the line are starting to happen often in our 40s and 50s. And so actually thinking about it around the menopause all makes complete logical sense. To, you know, prevention obviously will always be better than cure.
Oh my gosh, yes, absolutely. Absolutely. Thanks for that, Sarah. That it was really sobering. And I hadn't thought about the fact that many of the drugs or the treatment were actually, the research, for instance, were done on men. And even as I understand it, am I right in thinking that the symptoms of a woman having a heart attack are subtly different from a man?
Yes.
But actually that's not so well recognized, therefore. Is that
exactly? So the typical, if you see any sort of advertising on television or any public health messages, it's usually the classical crushing chest pain that goes into the arm, maybe with some shortness of breath and nausea, and that is a heart attack. It's the sort that you would see on Casualty TV program or whatever. But actually in a woman, although that can happen, with men, what tends to happen with their blood vessels is the blood vessels fur up with cholesterol and then they block. Whereas actually with women, we tend to have more spasm in our blood vessels. So that often the blood vessels aren't actually blocked because we've had that protection for the first 40 years of our life, but actually they go into spasm far more easily, which can seem like a blockage, but it isn't actually a blockage. So when you do Well, it means that it gives slightly different symptoms sometimes. Sometimes it can be pain, but sometimes it could just be breathlessness, or it could be palpitations. Some people, it can even be things like indigestion, or feeling like their bra's too tight, or, it can be more subtle.
Mm-hmm.
And women, unfortunately, aren't very, when they go to the doctor, they often, they explain things in a very roundabout way, and they go around the houses and they give far too much information, and they've already tried to interpret what's going on, whereas a man is much more matter of fact. I've had this symptom and that symptom, and that's that, and then the doctor takes over, if you see what I mean. So unfortunately, we often shoot ourselves in the foot just by virtue of our female personalities and how we explain things. But we'll often, a typical woman in her 50s might go to the GP and say, oh, I'm just so stressed, I'm running around, I've got this full-time job, my teenagers are causing me problems, my elderly parents are needing help, I'm run ragged, and yes, I do sometimes get this squeezing feeling and indigestion, and I get palpitations, and it must be stress. And actually, it's quite hard to unpick all of that. And even if that woman was sent off for tests, it's highly likely, or it's quite likely, that those tests will look normal, because it's spasm in the blood vessels, not actual blockage. So then she's told she's okay, and that she must be imagining it. But actually, if she had some proper help, maybe managing things like blood pressure, if that's not perfect, helping with the holistic care, what are you eating, are you exercising, those sorts of things, she would likely do better long term. And then actually proactively tackling her menopause would be really important, because tackling your menopause and replacing those missing hormones can actually really benefit things like how you metabolize sugar, how your cholesterol, your friendly and unfriendly cholesterol levels can be helped, about trying to institute regular exercise. So all of those things can be such an important part of, yes, drugs can be helpful for men and women, but we rely too much on drugs and we forget the basics. So it's a bit pointless taking a cholesterol tablet if you then live on very bad, saturated fatty foods and sugar and processed food.
Yeah, absolutely. That's exactly right. Exactly. And I do often say to a person that I'm seeing in clinic, well, when did you last have your blood pressure checked? I know that that's a really simple thing, but actually a lot of people don't know. They don't even know. And that's silent if you've got high blood pressure. So
yes, exactly. Yeah. So checking your own blood pressure actually is a really useful thing to do. I think most people think they have to go to the doctor and get it done, but actually checking your blood pressure at home is even more accurate, because you're usually a bit more kind of relaxed at home. But I think also, even those people, so many people come to me and say, oh, I've got that white coat hypertension where my blood pressure just goes up when I'm at the doctor. But actually, even that isn't as innocent as it sounds, because people who do get stressed in those sorts of situations, they are probably at a greater risk of having future heart disease, because the blood vessels are going through that sort of similar stress at lots of other times in their life. So it's not quite so innocent as it seems, but having a blood pressure machine at home is very helpful to keep an eye on that.
Yes, thank you for that. And then having your cholesterol blood test done. I think in the UK, the NHS, when a woman turns, oh gosh,
40.
Thank you. Then they're offered come in and have this check, and hopefully everyone takes it up. I'm sure they don't, but I'd like to encourage people to. And that is great. There's a baseline. There's a starting point as well. I think it is important, even though you're talking about more so with women, it's more about the spasming. Even so, cholesterol does have a relevance here.
Oh, absolutely. Yes, got a huge relevance. And for some people, treating their cholesterol is really important, but it's trying to look at the whole picture. So part of that NHS cardiovascular check that people are called for every 5 years, I think the problem has been that there was a bit of they had to go on hold during the pandemic. And then people, for understandable reasons, have now got out of the habit of actually visiting their GP surgery, because it's such an unusual thing to do these days. And so I think a lot of people aren't taking up the invitation because they don't really understand what it is or why they would do it, and they've got to take time out of their day to go and have the blood test. But actually it does, I mean, it looks at your cholesterol and all the different types of cholesterol we have, and it looks at diabetes, and it checks your liver and your kidneys. And then also, with knowing a blood pressure reading, we feed all that data into something called a Q-risk score, which has been developed through algorithms for years and years and years. And it, you know, it involves things like the patient's postcode, what their age is, whether there's any family history of any early heart disease, for example, lots and lots of other kind of questions and tick boxes. And you put in all the figures that you've got, and it gives you a risk score, which isn't, you know, again, it's all statistics, and it's not, you know, it's that there are pros and cons of that, but it gives you an idea of, are you at generally a low risk of developing a heart attack or a stroke over the next 10 years, or a medium risk, or a high risk. And that can then help us to guide patients in terms of, should we really just concentrate here on the lifestyle issues, or do we actually need to do the lifestyle issues but also think about medications like statins or medications if the blood pressure isn't ideal, for example. And you know, at our clinic at Health in Menopause, we will often, if a patient, well, you know, there's no need for them to have to, but if they want a more kind of holistic approach, we can do all those measurements and give them that idea of you know, is there other things to be thinking about. Purely focusing on just the hormones is kind of missing the point. We really want to get the whole of somebody healthy, not just one aspect.
Yeah, no, I actually think that's really great, having a really good detailed, if possible, a really lovely detailed blood analysis, and vitamin D as well, just finding out what level they're at for that as well. But we're going off track slightly here if I start talking about vitamin D and everything like that. So I think that's very important. I was understanding that when we're talking about lifestyle, I mean, I know we can get to food in a minute, because I know what helps based on fantastic research actually there is to do with cardiovascular health, but lifestyle wise, especially when you talked there about that woman, she's being pulled in all directions, it is a stressful time in her life, and then the hormones that helped calm her and also be stress relieving, the estrogen, for instance, is going away. Yes. And that's so unfair. Yes. It's really unfair. And so there are lifestyle things she can do. I mean, absolutely, she could definitely replace those hormones with hormone replacement therapy, which is very cardiovascular protective, which is fantastic. And then also there are number of lifestyle things she can do as well, and as importantly especially to do with exercise, because exercise is not only making you fit, literally keeping your muscle mass together, but it's stress relieving. It's so stress relieving. Any movement, any exercise is stress relieving.
Great for your psychological health and your physical health, isn't it? And I think that's the crux really of menopause medicine, is that in the ideal world we would get everybody on a super healthy lifestyle approach, and Bob's your uncle, that will make them statistically far healthier for the rest of their lives. The problem is achieving those lifestyle changes when you feel awful in your perimenopause or menopause can often be impossible. So, you know, I see so many women who are almost like a shadow of their former self, in terms of they did used to exercise, but then their joints got achy, and then they gained a bit of weight, because unfortunately that happens naturally as our estrogen levels decline. And so they have their motivations gone, because they no longer have their ovarian hormones. So they can't motivate themselves to actually go to the classes or go to the gym that they used to do, which then of course makes things worse in terms of weight and their mood. They may have other symptoms which are preventing them from exercising, like if they're a cyclist, for example, and they develop bad vaginal or vulval dryness or soreness, they may have to stop doing that. They probably not sleeping very well if they're awake at night with sweats and flushes, or worrying at night, or up and down to the toilet. So they've got no energy to make sensible food choices. And we all know that the less sleep we have, the more likely we are to reach for the unhealthy foods. So we can get in this real vicious circle where, although we know what we're supposed to be doing, there is no way in the world our body in its current form is going to make those things happen. So then we kind of feel even more guilty and self deprecating. So what I think one of the biggest roles of HRT is right, let's give you some of your hormones back again so that you can manage your symptoms better, so that those lifestyle adjustments then become achievable again. And it's like it's almost like switching a coin on its head. Is like, right, we can't do the lifestyle at the moment, unfortunately, because you're just in too much of a pickle. Let's help you with that by giving you some hormones, and then the lifestyle then starts to pick up.
Yes,
but
absolutely.
Then, but then in addition to that, by giving the hormones back, not only are you helping with the symptoms, but you're actually then helping with the future health, because, as you've already said, the cardiovascular system is so welcoming of having some estrogen back, and thinking, oh, often the blood pressure will drop a bit when someone goes on to HRT. There will be subtle, they're not amazing, but subtle improvements in cholesterol happen when you give someone their hormones back. Less people that take HRT develop type 2 diabetes, for example.
Yep.
Weight management often gets easier because suddenly the body is less stressed.
Yes.
And so if you protect the cardiovascular disease, you do a huge favor for the body. The trick really is knowing that and taking action at the best time, because there are better times to start HRT, and there's never a time when you can't, but there are better times to do it. So
when is the best time in an ideal world?
We call it a window of opportunity. Thankfully, that window is a wide, big window, but still it's helpful for people to know. So the best time to start HRT is if you're having any symptoms which are affecting your quality of life. So that, that's a very subjective measurement, that no one else makes that decision. You decide if you're having trouble. But so that can be in your perimenopause. So your periods may still be ongoing, but it's fine to start HRT if you're having difficulties. Or within 10 years of your last period, or before you reach the age of 60, whichever is the latter. Okay. So, for example, if I go through the menopause at the age of 50, the best time for me to start HRT would be before I reach 60. If my last period actually doesn't come till I'm 55, then I've actually got till 65 for my window of opportunity to still be open. And what that essentially means is if you start HRT in the window of opportunity, the benefits are profound and the risks are pretty much zero, especially with the up-to-date modern HRT we use now. If you've gone beyond your window of opportunity, it's not a no. It doesn't completely flip. The situation doesn't flip, so it's all risks and no benefits. That's not the case. Basically, if you're after 60, there are still benefits, for example, for your bone health and for reducing symptoms, which can still be very debilitating. The risks with the newer type of HRT don't really escalate much, but because our body is slightly more, it's already deteriorated a little by then, it just means that the benefits are less than they would have been if you'd started earlier. So we know from many trials that have all been sort of amalgamated that if you start HRT within the window of opportunity, your risk of cardiovascular disease reduces by about a half. Okay. So I mean, that is a massive kind of difference. If you start HRT after the window of opportunity, actually, as I said, you don't get as many benefits, and there doesn't seem to be any net benefit to your cardiovascular system if you look across the averages, but actually there doesn't appear to be any harm either.
Right. Yes.
Okay. It's just a more neutral.
Yes.
approach.
Yes.
Yeah.
Okay. But gosh, that's quite a statistic when you're talking about the benefits within that 10-year window of
Yeah.
roughly half the disease risk, the cardiovascular disease risk.
Yes.
And
Yeah.
that's fantastic. And you
It
add on
is
to that,
fantastic, isn't it?
you know, the once a person feels ready up to it, so to speak, you know, has more energy or sleeping better, you know, they can start perhaps exercising a bit more or finding time for themselves, that stress reduction. Then they can think, maybe I could just, perhaps my first meal of the day could be a little bit healthier. Just one meal they can change.
Yes.
You know, then you have this fantastic beneficial snowball effect that
Yes.
it can subtly, slowly just get better and better. I'm actually going to talk all about nutrition and cardiovascular disease in another podcast this month.
Excellent.
So I won't go into it massively here, but from my research, I noticed that Mediterranean style diet or way of eating is one of the fundamentally key
Yes.
beneficial ways of eating. And the focus, really, you don't have to live on the Mediterranean to eat that way. I always say to people, look at the focus of it is fresh vegetables, fruit, nuts, seeds, legumes, pulses, beans, whole grains, that sort of thing, fermented food, some dairy food, lots of seafood if you can, including obviously fish. And some meat is in it as well. So it's not too restrictive, but it's just about really a plant-focused way of eating with lots of variety and, of course, extra virgin olive oil. And I'm going to go into a lot more detail about that.
That's so tried and tested, isn't it? And, you know, I think Mediterranean diet, I think that the overall statistics would be along the lines of it would reduce the risk of cardiovascular disease by about 30% in someone, which is pretty much equal with, for example, if someone there's a study that came out in March of this year that showed that if we did 8,000 steps every day walking, that would reduce cardiovascular risk in postmenopausal women by about 30%. And then, you know, we know that HRT also reduces cardiovascular risk by up to about 50%. So actually, all those things are so beneficial, you know, and there will be some cumulative benefit. So if actually someone's doing all those things, you know, imagine the benefit. What I always find bizarre when we talk about risks and benefits is that, of course, it's great to reduce all your risks. Most people don't realize it because they don't know what would have happened if they hadn't have taken all the healthy options. You know, so I think sometimes we take things for granted, don't we? But you know, I think knowing what our biggest statistical threats are health-wise can then make a big difference in how we choose to tackle.
Yeah, absolutely. Absolutely. Gosh, Sarah, thank you very much. We've covered a lot, and thank you. You've made that so clear. That's wonderful for everyone listening and for me. And I feel, you know, quite motivated still to make sure I definitely get those steps in and things like that. And, you know, obviously food-wise, I think I've nailed it. But
yes, you've definitely nailed that. Yes.
And I'm on HRT, so that's great. So that's good. But thank you so much. That's really helpful. And also giving a person the big picture. Here we are. This is what we're actually talking about. People might not literally understand, well, what does cardiovascular disease risk mean and things like that. So it's been brilliant. Thank you so much. Thank you.